So, without any further ado, let me invite the first speaker to come. Gerry Marr is going to talk to us about a whole systems approach to supporting quality and efficiency. And I wonder, Gerry, if you could just kick off by just introducing yourself and giving people a little context about how you came to giving this talk.
Yeah,
Thank you.
Thank you. Good morning, everyone. I'm the Chief Executive of one of the regions in Scotland called NHS Tayside. We have 14 territorial boards who are responsible directly to the Parliament in Scotland for the efficiency and quality of care in our country. I come to this topic. I'm also the chair of the Chief Executives Group in Scotland, and we are working in a very determined way nationally, really to prove a very simple proposition. And the proposition I want to put to the audience this morning is that despite the recession, despite the fiscal challenge, then I think we can achieve efficiency and take costs out of our system, and at the same time drive up the quality of care that we deliver to our patients. And so, unfortunately, this slide didn't translate when we downloaded it, but it's to do with economic forecasts. The interesting thing is that when you look at economics, it always looks confusing anyway, so I'll move on to the second slide, which is more of a narrative of the challenge that we face in Scotland, which I think are the challenges certainly that face across the whole of Europe and many other countries beyond. If we actually look at the figures, the one that matters to us is the second bullet point, that the prediction in June 2009, which is proven to be accurate, is that we are seeing a real terms reduction of between 7 and 13% over a 4-year to 5-year period, and that's the environment that Scotland finds itself in. That's against a backdrop of growth of 6% in the previous 5 years. So the turnaround is really quite dramatic, and the challenge is very, very significant indeed. And so we've been thinking very hard about how we order ourselves into challenging this. At the very time that Scotland was confronted with that deficit challenge, we published our healthcare quality strategy quite deliberately. We were not going to be put off by simple fiscal considerations. And the healthcare quality strategy, which you can see at the stand in the exhibition hall, really embraces what we now recognise from the Quality Chasm report in 2000, the 6 dimensions of quality, which underpin effectiveness, patient-centredness, etc. And I think that in the systems I look across the world, those 6 dimensions are becoming regular in the way that they're presented as a way of driving up quality. And so the healthcare strategy for quality in Scotland is about care being person-centred, being clinically effective, and most importantly, being safe. And in relation to that, we have built up a national infrastructure that's supported by myself and Derek Feely as the Director General in terms of dimensions of safety, dimensions of effectiveness, person-centredness, and also importantly the infrastructure that we put around the national programme in terms of measurement, e-health. Our quality improvement hubs, of which the third speaker will make reference to, are very important infrastructure issues that are built up in a sustainable and national way. But at the same time, we had to recognise that we have to drive efficiency in our system. And we have published our NHS Scotland Efficiency and Productivity Framework over the last 3 years. We see quality and efficiency as 2 sides of the same coin. Far too often in healthcare systems we see the so-called quality initiatives with poor evidence and new developments being driven through, often under clinical pressure, which are not necessarily evidenced as being a drive for quality, but often cost more. And then we see the fiscal people driving very, very short-term cost reduction programs. In my country, the favourite word of our finance directors is CRES, cash releasing efficiency savings. They are nothing like being efficient. They are short-term ways of just driving fiscal cash out of the system, and very rarely do they do anything other than reduce quality. Our ambition is to balance in the middle of this diagram, to actually improve quality and reduce costs. And we believe there's a way of systematically thinking our way through that. And so we now see quality and efficiency as one and the same thing in our Scottish system. And I've translated that into our Tayside system in a structured programme that I want to share with you. I'm just looking at just how small the writing is on these. These slides, of course, are available after the conference. But our ambition is to improve the overall quality and efficiency of NHS Scotland and achieve our financial targets. I am responsible to Parliament in Scotland to break even. I have a statutory responsibility to deliver break even. If I don't break even at the end of the year, I get fired. We have broke even for the last 13 years, so that's why I get the privilege of still standing here today. If I'm not here next year, you know what happened. And the work streams that I want to talk about: variation, waste and harm. Because we have established work streams in our local system to tackle the whole issue of waste, harm and variation. I don't know what the waste is in your system, but it is abundant. I don't know what the variation is, but it exists. And I don't know the level of harm, but we do know from published international data it can be anywhere between 17 and 20%. So each of these programmes that we talk about are actually looking at the whole issue of waste, harm and variation in our systems of care. So what we talk about is finance. Clever people will fix the world economy eventually, and it will be painful, but they'll get there. The one thing that no one can fix is a demographic time bomb that faces us in terms of our older population and how we're going to tackle extraordinary growth in older people in our communities. I remember one of our colleagues in Singapore actually referred to it as a grey tsunami, which is quite an interesting way of describing it. Inevitable and persistent. But the way I want to talk about it is by tackling the issues of waste, harm and variation in our systems of care. And my proposition is that you have to have a structured, detailed and relentless programme tackling these three themes if you're actually going to take appropriate measures to reduce the cost and improve the quality in your system. So we talk about having two choices. There are a group of CEOs and directors of finance and others in our system in Scotland who regrettably, I think, would pick and drive all their efforts around the issue of surviving. We call it the 5%, because typically that's a cost base that you would have to take out in our system. And what I say to my colleagues is that, yeah, you probably will survive. I'm not sure what it will do to your quality, but will you thrive? And my proposition in my country, and my challenge to you from where you come from, is that if you concentrate on the 95%, the abundance of resources that are available to you in your system, then you have more than enough money to actually deliver high quality care. And I know that that doesn't feel like it when your nose is up against the pane of glass and worrying on a day-to-day basis. But let's think about the 95%. Let's not think about short-term measures to take cash out of the system. For us, if we fail, our major teaching hospital is called Ninewells. We've calculated that if we do not transform our system of care, if we do not redesign, root and branch what we do in the way that we deliver to our communities, we'll actually have to build a 500-bed hospital by 2031. We're not going to do that because we couldn't staff it anyway, because all the young people that work are actually moving in the opposite direction. The proposition that we somehow build our way out of this crisis with more resource, more infrastructure, more capital is not a sustainable proposition in the modern world. Now, let me just share with you some examples of evidence in waste in the system. 4 years ago, we did a very deep dive into our system and we analysed it from top to bottom. And I could spend the next half hour showing you slides on waste. But I'm not going to do that because they look pretty grim. But there is waste in your system, and you have to measure it, and you have to understand how you're going to tackle it. This is just three specialties. I'm just taking out one slide of our work in our outpatient departments: orthopaedics, ophthalmology and dermatology. 34% growth in new attendance over 5 years. 10.7 million unwanted costs, with 21% increase 2012-13. This is just waste in the system. This is processes of care that drive referrals from primary to secondary care in an unwarranted and unjustifiable way. And the opportunity costs are 45 million business based on the current tariffs that we publish in Scotland. These are huge amounts of activity and huge amounts of money that we have to tackle. And just to put it into perspective, over the last 5 years in our programme, we have taken about, cumulatively, we have taken about £100 million cash out of our healthcare system, of a system that has about 850 million. Our government, God bless them, let us keep that money. We don't give it back to government, we keep it to reinvest and redesign our systems of care. And so, in good old-fashioned improvement way, we are creating value in outpatients by driving waste out of the system, and this is just the driver diagram that we are eradicating ineffective acute outpatient attendance, utilisation, community-based assessment and diagnosis, and delivering our 2020 vision through our contract with government. But even more interesting is the evidence of clinical variation in our systems of care. And I should probably use the term unwarranted variation, but clinicians get upset at me when I don't put the word unwarranted, because variation is inevitable. But unwarranted variation is not. And I believe that it's evident in any healthcare system I've visited in countries around Europe and in the United States. You don't really need to. This slide is actually the expenditure per patient in every GP practice. So we are, in Scotland, we have primary care and we have general practice, and every patient is registered in our country through a GP. The dark colour is the elective referrals and the cost of, and the blue is emergency care that traces back to primary care. The variation on the very nearest part of the chart is our least cost practice in Tayside is £253 a year per patient. Our most expensive is £983. The variation is staggering. We have done a huge amount of work in looking at this with our GPs, and we're eradicating variation through programmes such as anticipatory care that I'll make reference to later on. And significant variations in prescribing. This begins to show the same pattern. These slides show a pattern of variation in prescribing. And not time to talk about it today, but much of our programme has been on tackling issues in relation to inefficient waste and variation in our older people's care programme. There are 800 people over 80 years of age in Tayside on 20 drugs or more. 800. Not now. There was when we started. The good news was that they aren't taking them, because if they were, they'd be dead. That's the only one thing we know for sure. But we really had to tackle the issue in a very sustainable way. This is the difference in the prescribing of hypnotics and anxiolytics per 1,000 patients in Tayside. Extraordinary variation in the pattern of prescribing. And I'm only picking these out as little snippets. I could give you a sustainable and evidence-based pattern of prescribing, of cost in our primary and secondary care systems that is... Oops. Carrie, could you fix this one? By the way, I'm a complete IT. I wouldn't know how to Twitter if my life depended on it, so I need to ask Carrie to remove that for me. Thank you. The other challenge for us in work that we've done in Tayside is a concept about failure demand. In Scotland, we've done a big piece of work that suggests, and I know this sounds improbable, that 40% of public spending, and I'm talking about the money that we spend in social work, the money that we spend in health, across that sector, that we actually spend 40% in what we call failure demand. We actually do not get the results that you would anticipate in terms of improving the health of the population. So we're actually spending money on nursing homes, on older people's wards, on infrastructure, instead of spending it preventatively, and I'll talk a little bit about that. So that's why I say that if we reorder our thinking, if we transform the way that we deliver care, then there is sufficient resources in the system to achieve financial balance. And for us, deprivation and inequalities in Scotland is a huge challenge. And in the city of Dundee, which is our main city in my region, the deprivation factors are really as comparable with some of the worst figures in Europe, regrettably. And these are just some of the failure outputs that we have for children. For adults prescribed 20% anxiolytic depression. 3 in every 10 adults admitted in an emergency, life expectancy is 10 years or less. Our range of expectancy of life in Dundee City ranges in males 56 years of age in the worst deprived areas, with the national average being 72. The scale of that challenge is enormous, but regrettably, we're spending it in infrastructure that isn't appropriate. It will not resolve the problem of the quality of life for individuals that we tackle. So for us, what we need to do is we need to reduce failure demand. We need to close hospitals. We need to close nursing homes. We need to divert resources into community-based programmes that engage citizens in a fundamental different way. You'll hear a little bit from Maureen on the prevention of and early intervention, our collaborative in early years. And we need to plan much more locally. Too many health planners take the grand view of what healthcare should look like in a global sense. We have to actually plan at the level of our communities that makes a difference. And so for us, the leadership challenge is our statutory responsibilities are there. We need to deliver them, but we also need to create capacity and capability within the system to realise the potential for reducing unwarranted variation, waste and harm, as well as the negative outcomes that our communities actually experience. And later on in the conference, I am talking about our older people's strategy, but one of the highlights of this approach is that, for example, in things like assessment and diagnosis of dementia, that is now a community-based programme. We have closed all of our dementia assessment beds in the region. In part of the region, we're rolling it out across the region. At a time where we are challenged by our 75-year-olds, over 75 in admissions to hospital, we've actually been closing elderly beds, and we have reduced our bed days in the over 75s by about 22% over the last 2 years. Now, this is done through a programme called Steps to Better Healthcare, which is a systematic and deliberate attempt to answer the 95% question. If any of our systems are proposing changes in the way that we deliver healthcare, our demand on them is that they have to demonstrate that they are not taking a quick fix out of the system. They're actually tackling the way of redesigning the 95%. I think that our friends in Jönköping in Sweden have got it absolutely right when they say that efficiency is an ethical property of their organisation. They actually describe our responsibilities to spend what is not our money. In Scotland, it's our taxpayers, it's our community's money, to spend that properly and wisely. And the way to do that is not to take short-term cuts in staffing, short-term cuts in closing facilities where there is no evidence that that facility isn't needed by the community. These are all issues that we have to tackle, and Carrie will say a little bit more about how we are structuring that. The simple truth for us is that there is no more money. There will never be more money. What you've got is as good as it gets, is our message in the UK. And so our ability to transform our public services is to be ruthless and relentless on the issues of waste, harm and variation in the system. And I would challenge you just to go back and think about that in terms of your own system of care. When we got this quote at first, my chairman of my board's a bit of a scholar, so he actually decided he wanted to know who George Wood Bacon was. I just like to quote It turns out he's a physician in the 19th century. So fortunes are not made in the boom times. They're made in the lean times where we have to reorganise ourselves, gather our resources, think differently, and transform our systems of care fundamentally. I'll stop there and happy to take any comments or questions.
So, Gerry, thank you very much. There's a very provocative statement from a chief executive who's doing it. And it's very clear that Gerry means it. So we're going to have a couple of minutes for questions, but let me just lead off while people are thinking about that. And the first question I have, Gerry, is that I talk about waste and variation in my system as well, and that leads to some pretty spirited discussion with our clinical leaders. Mm-hmm. That wouldn't happen in Tayside.
No, every day it does, yes.
So tell us about how that happens and how you manage that.
So we talk about you need to know the conversation you're in, as a CEO in particular. So I say to my clinicians, this is an improvement conversation, not a judgment conversation. I'm not going to point the finger at clinicians and say, look at that variation in prescribing, look at that variation in your clinical practice compared. So, for example, we use a clinical system called CHKS, and our colleagues in ENT, I saw a huge opportunity for improvement. We gave them the data and said to them, take 6 weeks. We're not going to make a judgment, and I'm not going to tell you what to do. And come back and tell me where you recognise the need or the opportunity for improvement. And they did. They came back because the relationship was not a CEO beating up on clinicians and saying, this isn't good enough, we need to fix this variation. We said, this is an improvement conversation.
So here's the data, you interpret it and work out how to fix it.
Yeah.
From our Twitter colleagues, do you have any questions or themes that you want to raise? Your microphone?
We have one comment and one question.
Sure.
The comment says, you call them the 5%, I call them the firefighters. The NHS needs more planning. Would you like to comment on that?
Just what was the first part of it, sorry? I call it the 5%.
You call them the 5%. I think this is when you were talking about the different 95 and 5% of people doing different things.
Yes. Well, what I really mean about that is that if every meeting and every planning meeting is designed to just talk about, if you create the language in your organisation of fiscal control, you get an organisation that's risk averse and simply tries to control. My challenge is that if you're a transforming organisation, you systematically look at the 95% of resources that are available to you. I'm not interested in the 20 million target that I have to save every year. I've saved it for 13 years. But we've did it by working through our 95% monies. We're not shaving money off the system all the time. Any question?
And you have a question?
We have a question. Someone has asked you to list the quality infrastructure components required to deliver a whole systems quality improvement approach to Tayside in Scotland.
Yes, and well, in actual fact, I'm talking about that tomorrow. I'm actually in a session with Kaiser and with Singapore, where we are talking about how you create real ideas and execution. And I'll be talking about we have created a very significant infrastructure to drive quality and measurement in our system. And if you want a reference, Anthony Staines, PhD, when he examined Intermountain and Yongshipping, produced a PhD on the characteristics of high quality healthcare systems. If you look at Anthony's diagram, then you look at how we've built our infrastructure.
So that will make a very interesting session tomorrow, because I think that's going to be very powerful. Any pressing comments or questions from the audience before we go to the next speaker? If not, Gerry, thank you very much.